Okay, so if you're ready, can I start the timer?
Yes, ma'am.
Right. Okay, I'm starting the timer. Here is the timer and here is your question. Right, if you have read and understood and considering it critical to your station, kindly begin your station and tell me how would you manage this patient.
I'll be managing this patient according to ABCDE approach. I'll make sure patient has an adequate airway and patient is adequately breathing. Afterward, I'll make sure the patient has 2 large bore IV cannula and patient being adequately resuscitated. Once the patient being resuscitated and stabilized, I'll go through the history and the previous examination and all the previous past surgical history. Then afterwards I'll see her the CT scan as it shows it to be the enterocutaneous fistula most likely, and for this I'll make sure that I'll do get the fistulogram done along with the CT scan, and for her sepsis I'll keep her on the good empirical antibiotics, and if the abdominal wall abscess is actively draining the pus, I'll send the culture before starting the antibiotics, and along with that I'll start the patient on the nutrition, so in order to maintain her adequate nutrition levels, and afterwards I'll make sure that the patient has all the baseline has been gone, such as the CBC, UC, LFT, uh, PTINRs, and certain electrolytes such as the copper, manganese, and magnesium, calcium, and I'll make
Okay,
sure
can you tell me, according to your opinion, what is the provisional diagnosis? What is patient suffering from?
as per the history of cholecystectomy and a huge abdominal mass, and the CT scan itself shows there's a communication between the gastric jejunostomy and the abscess cavity, it's more likely to be the enterocutaneous fistula.
Can you define the term fistula?
It is a basically the term fistula is defined by a track line by granulation tissue, and there's a communication between the two epithelial structure. And when we label it to be enterocutaneous, it would be a communication between the skin and the GIT, and would be lined by the granulation tissue in the tract.
Okay, can you, is it possible for you to classify fistula?
Yes, ma'am. It could be there are so many ways. It could be anatomical way or on the basis of output. On the basis of output, it could be low, moderate, and high. And low, it could if the daily output coming from the fistula is less than 250 ml. If it's between 250 to 500, it's moderate. If it's more than 500 per day, it's high output. On the basis of anatomy, you can also classify it to be enteroenteric, enteroclonic, enterovesical,
Yes.
and enterocutaneous.
Is there any other way you can classify fistulas? That
No, ma'am, I don't know.
have you heard of the term high output fistula and low output
Yes,
fistula?
ma'am.
This is the
Yes, ma'am.
physiological
Ma'am,
way of classifying. Yes. And
I say that low and high
okay.
output I start
And then there is
initially.
congenital way of classifying as well, and then there's etiological way of classification as well,
Yes,
based on
yes.
infection, inflammation, malignancy, etc. Okay, can you tell me what are the images that we can use for the diagnosis in this?
Then we can do CT scan abdomen with along with the CT pelvis with oral IV contrast. Along with that, in order to delineate more and more anatomy of the fistula, we can do a fistulogram as well.
Yes, very good. Okay, can you help me and read this image? What are you
Okay.
looking at?
Ma'am, this is more likely to a fistulogram in which I can see
Yes,
the catheter that has been inserted on the skin and has given there's a dye which has been given through this track
yes.
and it's pooling inside and
So
and
kind
I
of
don't
matches.
it
Yes,
seems that yes it seems like a bit in the gut, so as I can see the other bowel shadows in the background, so it seems
yes,
like abdominal communication of
yes.
the skin with any bowel lumen. For this to delineate more, I need more film so I can confidently say which part of the bowel wall has been involved.
Good. Okay, can you tell me if you don't manage this patient, what are the complications that can result?
Ma'am, these patients are more predisposed for electrolytic imbalance and the fluid imbalance and the other nutritional imbalance in the longer term. So if they would have, if their nutrition and fluid not been replaced adequately, it has to be done in the very start. If it's been low output, you
There's a
can wait.
triad. I want to hear three different reasons. You have given me one only, that there's a fluid and electrolyte abnormalities. What other
And it can lead to the
complications?
sepsis, and it can lead
Yes,
to the sepsis,
and
and furthermore, and it can lead to sepsis and more inflammation,
malnutrition. Malnutrition is the
malnutrition.
third one.
Proceeded
Okay.
first. Hmm.
Yes, can you tell me what kind of acid-base balance it can result into?
Ma'am, it can lead to the if uh, ma'am, EC fistula are you talking about?
Yes,
Ma'am, it can lead to
because there is a loss of fluid. It's continuous. One, it will cause excoriation of the skin, which comes in contact, and it also causes metabolic acidosis when there's loss of alkaline, like pancreatic juice a lot. So that's one complication that can occur.
okay.
Okay, can you please tell me what are the surgical management options you can offer this patient?
Ma'am, it depends. If it's being low output, I can give a trial of conservative management after making sure the SNAP trial has been done. If the patient does not respond to my conservative management, I'll have to, or if the patient has a sign of peritonitis and the sepsis, in these two scenarios, I would have to opt for a surgical management. In these, I have to excise a whole fistula tract along with the bowel wall that we involve in formation of the fistula, and which can be later on followed by making any ileostomy, colostomy, or later on followed by the anastomosis, or in the first step, I can do the anastomosis.
Okay, can you tell me what are the risks or predisposing factors which can result into intracutaneous fistula?
Ma'am, there are multiple such as there is a foreign body, radiation, infection, inflammation, neoplasia, distal obstruction, steroid, and there's certain kind of systematic diseases such as the Crohn's disease, tuberculosis.
Yes, good. How should the nutrition of this patient be maintained?
Ma'am, if the patient being a low output or high output, if the patient being low output, I can start patient on giving the bulk nutrition, providing the patient a high protein diet. Patient respond to it. If the patient having a high output fistula, and this I cannot opt for enteric nutrition, I'll have to go for parental nutrition, such as
Yes,
the TPN.
yes. How much is the normal energy requirement of the patient?
I mean, normally it's 25 to 30 kilogram per kg per day. But in a case when there is a severe stress, it increases to 35 to 40 kilograms per kg per day.
Okay, good. Can you tell me why, if you'll do the blood test of this patient, why there'll be low sodium potassium bicarbonate?
Ma'am, it is for the same reason as being the gut content keep on excreting from the fistula and it's not getting reabsorbed. So there are more and more loss of the sodium, potassium, and the other electrolytes.
Okay. What are the signs or symptoms of sepsis that you'll look out for?
Ma'am, basically, first of all, I know there
Intra-abdominal
is this.
sepsis, yes.
Okay, first of all, I know there is a intra-abdominal abscess. There is a foci of inflammation. Then I'll look for the sign of surge, such as the patient being tachycardic, the pulse more than 90, and the TLC is either less than 4 and more than 11, and the patient being having a respiratory rate of greater than 20, and the patient temperature is less than 5 for more than 37 degrees centigrade. if any of two are being met with the context of the abdominal abscess, I can label the patient as being sepsis, in sepsis.
Okay, can you please tell me what are the factors that prevent spontaneous healing or closure of the fistula?
And there are two important things. First, the distal obstruction and the infection and inflammation. So if you rule out these two things, the fistula can be healed.
Okay, right, I think we have already done.
Okay.
Uh, where is all right? Yeah, we have already covered almost. Yeah.
Mm.
Okay, who would you involve in the management of this patient?
And this would be a multidisciplinary approach. I'll be making sure that I'll have a surgical doctor, enteral medicine doctor, and a nutritionist in this.
Yes, and where should this patient be managed?
Initially, this patient should be managed in ITU, and as soon as the patient being stabilized, I can shift the patient in the SU and later on in the ward.
Okay, good. Thank you.
Thank you, ma'am.
Thanks. Yes. Okay. Anyone want to give feedback to Dr. Teshaba? It was good.
Thank you, ma'am.
Just little bit about classification. You can read more, but like you had full command on the topic, so it was good. Hardly you gave me any points. Yes, she did well.
Actually, ma'am, the thing is, I have read two classification as I discussed you on the basis of output, or the other was on the basis of anatomy. So, aren't they two enough, or should I go for the other way? Because I
Uh,
classified.
I asked you open question. You know, it depends how the question is put forward at you. I asked you what are the possible ways you can classify. So then you should come up with all the possible ways. Like if
Okay,
they ask you what is the classification, then you can maybe say one or two. But then if it's possible to classify in other ways as well, then why not?
okay,
So
ma'am.
one thing is like not to depend on those ready-made things. Instead, open the books and make your own notes. Once you'll understand and have your own notes formation, then you'll understand and then you won't forget even in the condition of stress and press. So yeah, this is what we want.
Okay, ma'am.
Thanks.
Thank you, ma'am.
Thanks. Right. So Dr. Mohammad Ilyan has joined as well, and Dr. Mohammad Al Tahir is here as well. Dr. Aisha is here as well. Who would want to go first? Yes, Dr. Mohammad Al Tahir. So if you're ready, can I start the timer?
Yes, I'm ready.
Okay, good. Even network sounds better today. Okay.
Good.
I hope it stays.
Yeah, it should be fine. Inshallah.
Okay. So, oops. Yes. Okay. Right. All right. Okay. If you're ready, I'm starting the timer.
Okay.
Yes. And here is your question. Right, if you have read and understood, let's begin the session. Can you identify what are you looking at?
It is posterior aspect of the knee joint.
Okay. Can you tell me the boundaries of the knee popliteal fossa?
Okay, superiorly and laterally there is the biceps femoris, and superior and medial there is semimembranous and the semitendinous muscle. Inferior and lateral there is the lateral head of the gastrocnemius muscle, and inferior and medial is the medial head of the gastrocnemius muscle. The roof is formed by the deep fascia, pierced by the short saphenous vein, and the floor is by the posterior aspect of the knee joint and the popliteal muscles.
Can you tell me the contents of the popliteal fossa from superficial to deep?
Okay, it's superficial. There is the tibial nerve, and then the popliteal vein and the popliteal artery, and then the common peroneal nerve, and then the popliteal lymph nodes.
Okay. Can you please tell me if there is a swelling on the back of the knee, what are the differential diagnoses that you can think of?
This can be a sebaceous cyst. It can be a popliteal aneurysm, popliteal artery aneurysm, or it can be neuroma or fibroma, or can be fibrosarcoma, or it can be tumor of the tibia
Yes.
of the femur.
Okay. Can you please identify structure 15 here? Okay, first 15 over in the picture A.
It's a tibial nerve.
Yes. Okay, can you please identify structure 11?
It is the semimembranous muscles.
2.
The common peroneal nerve.
Okay, yes, please. 18, if you can please identify.
It is the solar nerve.
Good. 13, please.
This is the short saphenous vein.
Very good. If we can move on to picture B, can you identify 8, please? Yes,
The
8.
popliteal artery.
Okay.
The
And
popliteal artery.
yes. Okay, 10, please.
It is popliteal branches to the medial head of the gastrocnemius
Popliteal
muscle.
vein. It's popliteal vein. See, this is
Okay.
artery coming, you told me correctly, and this is vein.
Okay.
See, and artery being the most deepest, so it's above. All right, okay, can you identify 16, please? Tibial nerve. Okay, 14, please.
Tibial nerve. Okay. It
14.
is solar nerve.
Okay. Can you tell me, yes, can you tell me the branches of the popliteal artery?
Okay, it is the anterior tibial artery, and this branch of the, and also there is the genicular artery, superior and inferior, medial and lateral genicular artery, and there is the tibioperoneal trunk, which is divided into posterior tibial artery and the peroneal artery.
Okay. Can you tell me, please, how the knee joint, what kind of joint is the knee joint?
It is ball and socket joint.
Ball and socket.
No.
Of course not. Okay. Can you please tell me how the knee joint is stabilized?
It is inspired by the
What?
medial and lateral
Yes.
meniscus and the anterior cruciate ligament and the posterior cruciate ligament.
Okay. What is the function of menisci? How do they get their blood supply? Menisci of the knee joint. Yes.
I'm not
In
sure.
which position knee joint is most stable?
At the extension.
Okay. Okay, which structure prevents posterior dislocation of the knee joint?
The patella.
Okay. In case of dashboard injury, how a patient presents? What is the common presentation?
Sport injury. I don't know about this.
Dashboard. Okay. Can you tell me how would you examine the patient if patient presents with anterocruciate ligament rupture?
Okay, this is called the Lagman test.
Yes. How would you?
With
Yes.
the knee flexion at 30 degrees.
Yes.
One hand is it's placed on the thigh, and the right hand is placed on the upper part of the leg, and will be forward movement of the thigh over the knee joint. Excessive movement, this means the test is positive.
Okay. How many bursae are there in the knee joint? And inflammation
2.
of only? No. And their inflammation is called is called what? Okay, you only know about 2, but there are few more. You have to go back and
Okay.
read. Okay. All right. If a person gets comes across RTA, road traffic accident, and neck of fibula gets fractured, then which nerve is more likely to be injured?
The common peroneal nerve.
Okay. You said it's the most deepest or it's most lateral?
It is the most lateral.
Yeah. So how
The
would the
deepest part
patient
is the
present?
popliteal artery.
Yeah, deepest is popliteal artery. Can you tell me how would you take the pulse of the popliteal artery?
With the knee flexed at 30 degrees,
Yes.
the thumb should be placed on the anterior surface of the knee, on the patella,
Yes.
and we pulsating by the middle fingers.
Okay. Good. So tell me. All right. You told me that. What more is left? Valid one. Okay. Thank you. But you know what are the things you have to read.
Okay,
Thanks.
thank you.
Thank you, Dr. Aisha. Can Dr. Tashaba you help her? Because
Yes,
she has
ma'am, sure.
communication skill station. So ready, Dr. Aisha and Dr. Tashaba?
Yes, ma'am.
Yes, ma'am.
Dr. Mohammed got disconnected. Dr. Mohammed again. Maybe his network. Okay, if you both are ready. No papers, no pages, no cheating.
Ma'am, to write down anything. If
Okay,
just I hold the pen and paper to write down anything. If
yeah. Not to read
no,
the
no, no, no,
questions
no,
or
ma'am.
anything else. Okay. All right. If both of you are ready, I'm starting the timer. Yes. Just get settled so it won't have the squeaky noise. All right. If both of you are ready, I'm starting the timer, right?
Okay, ma'am.
Okay, ma'am.
Yes. Here is the question. Not too much. Right, if you have read and understood, kindly begin your station.
Okay. Hello, I'm Dr. Aisha, one of the surgical house officers. Can I confirm your name and date of birth?
My name is John, and I've been born back in 1965, August 15.
Okay, Mr. John, it's nice meeting you. So I've been asked that today I have to discuss with you regarding one of your investigation that you have to undergo. Do you know up till now what's the disease you are suffering from?
On and off, I have this complaint. Whenever I eat food, it's become very troublesome for me to eat anything out. It sticks on my throat, and I'm unable to digest and swallow down anything. It's been like 6 months or so.
I'm so sorry to hear about that. Do you have any idea about the investigation that you're about to undergo?
I don't know. I heard there's some camera that will go inside my mouth, and I am a bit cautious about what's gonna happen to me.
Yeah, I can see your concern. Actually, if you allow me, I would try to explain it to you. What is actually this test called, if that's okay?
Okay.
That
Okay.
test is known as esophagogastroduodenoscopy. It's a difficult term. Actually, it means that the camera would be put into your mouth and it would be then taken down through your food pipe into your stomach and then in the first part of your small bowel. And from there, the images would be relayed onto the TV screen. Are you getting me?
Okay.
Yeah, and then those images would show us the interior of your food pipe, about your stomach and bowel, if there's any disease or problem ongoing. And then apart from that, we can take some of the cultures and some of the from the lining of the food pipe and stomach. We can take some sample to for the test to be carried out, and along with
Why do
that,
you
we
want to
can
take a sample?
to know the cause of the to know the cause of the problem that you are suffering from. Sometimes there are certain infections and sometimes there are certain malignancies that are undergoing, so we need to
That do
rule
I
out
have a
that.
cancer?
No, I can't say. This is too early to say at this point. This is, you have to go undergo this investigation, and then apart from that, you may have to undergo a number of other investigation if you could not find out the reason. It's too early to say at this point.
Okay. Would I be awake during the whole procedure?
I was about to tell you that during this procedure, we'll offer you some anesthesia, which means that you'll be given some numbing medication through your IV line, and you will be put to sedation. You would be drowsy, and you won't feel any pain, and you will not be awake during the procedure. That's all right.
Okay.
And do you have any other question?
Can I eat around when I have this procedure going on?
No, because you will be completely drowsy during this procedure. And before this procedure, you can have 2 hours before the procedure, you can have fluids and liquids, but you need to fast at least 6 hours before the procedure. You can't have any diet, soft diet before the procedure.
So, doctor, what could be the complication of this procedure that you're going to do on me?
As Mr. John, you know that any procedure is not free of complications. Like this procedure, we can have some bleeding from your inner lining of your food pipe and stomach. We can introduce some of the aspirate into your lungs, and it can cause some chest infection. Apart from that, it can cause damage to your teeth in the mouth when we'll introduce the camera. And the most serious complication, I'm afraid, it's really very rare, is that we can cut through your, food pipe along the complete lining of the food pipe, and there could be a tear in the food pipe, and that's, I'm afraid, the most serious complication. And if it occurs, you might have to go to surgery. Are you getting me?
Aren't there any aren't there any other alternative?
Yeah, the alternative, you have already undergone the imaging investigation. They've already carried out, and that shows, I'm afraid that it shows that narrowing in your food pipe. So we have to undergo. My advice would be you should undergo this procedure so we can properly manage out your problem.
Okay. How likely is it that if in case my stomach got perforated or got ruptured during the procedure, how likely is this? In how many cases have you seen this?
Yeah, because I've first let me be. I'm just make to tell you that be assured that you're in the best surgical hands, and you're the most experienced person is going to perform this procedure. So in these expert hands, the surgical complication rate would be much lower. And even if it is diagnosed during the procedure, we can repair it at that time. And because I've listed all the complication, it does not mean that every complication is gonna occur in your case. It's really very rare. So
So
you need
doctor,
not
are
to
you
be
gonna
afraid.
do? Okay, doctor, who gonna do this on me? Are you gonna perform the procedure?
No, I'm just a trainee doctor. I'm not allowed to perform these kind of procedure. My consultant, he's going to perform this procedure. He was actually busy at the moment. That's why he asked me if I can, if I can gain consent from you, if that's all right.
Okay.
Do you have any other questions?
Yes, you can tell
No,
why the
doctor.
patient keeps on salivating.
Okay, this is this is the reason, because of the narrowing in your food pipe. The secretion that is produced by the food lining, they can't go downward. There is a bit narrowing and obstruction distally, lower down. That's why they just come out from your mouth, and you keep on salivating. But once we will find out the cause of this narrowing, we can treat it. Are you understanding me?
Yes, can you
Yes.
tell if smoking and drinking has caused me cancer?
This is not we could not say it, with surety. It can increase sometimes the chances, but this is not the cause in every problem, in every case. So we can't say this is the cause of your problem.
Okay, then you have to give the advice. Because of sedation, patient will not be able to drive car back home.
Yeah.
So
Yes.
So
that
if you,
advice.
so Mr. John, actually, the anesthetist is going to decide about the kind of the anesthesia that would be given to you. There are actually two kinds of anesthesia that you could be offered. One is the in which a numbing medication would be entered through your IV line, and you would get completely drowsy, and you would not be awake during the procedure. And the other is that the gas would be, a mask would be placed over your mouth, and a gas would be introduced through your airway into the lungs, and you can get drowsy after that. There are certain pros and cons of each type of anesthesia. If we go through the gas anesthesia, then obviously you will be recovered early, and you can eat and drink after 30 minutes, and you can drive back home yourself. But if we go to other kind of anesthesia, the numbing medication, then you can't drive yourself. You need someone to look after you, and you can't eat at least 4 hours after this procedure. Are you getting me, Mr. John? I'm sorry, it's too
Yes,
much for
doctor.
you. Okay.
Okay.
Now, but then if you have to summarize.
Yeah, at the end you
No,
have to
she didn't
summarize.
ask me for the consent till yet.
This was not consent.
This
It
was
was
all consent.
counseling.
Okay.
It's
Only counseling. Okay.
counseling. Yes,
My bad.
just counseling. She was doing counseling. One
Okay.
question: when patient says if my drinking and smoking is linked, your answer was good, but then you can also add yes, literature studies
Studies.
have linked it with cancer, but we cannot be sure.
Okay, ma'am.
Like you answered, so it was good.
Okay. Okay.
Yeah. What more? Yes, if biopsy shows calcium, how would you manage me
Cancer.
If
with
biopsy
this
shows, sorry.
calcium?
Cancer.
Yeah. Then, Mr. John, we're gonna discuss. I need to involve my rest of other colleagues, and we need to discuss your case in multidisciplinary meeting. And then you have to undergo CT scan of your body, chest, and abdomen. And then, after the staging of your cancer, we can further proceed after discussion with MDT towards your
Good.
treatment. That would it be a conservative management or palliative treatment, or would I will go towards the surgery? But at the moment, we need to wait for the results of the biopsy. That would take 2 weeks.
Good.
Okay.
Yeah, good. Good. Yeah, that was it. Anything else, Dr. Tashaba, would you want to add?
No, ma'am. She did pretty good, mashallah.
She did very well, yes. And it
Thank you,
was
ma'am.
like random for her. She didn't tell
Yeah,
me that she will do this one. I got this randomly for her. So
maybe it
good.
was an easier one. I like OGD and colonoscopy
Yeah, but it's most commonly asked. That's why
Yeah.
I got this one.
Yeah, okay. They're difficult ones that I was just keeping my fingers crossed.
Oh, okay. But you'll be able to do those as well.
Yeah, inshallah.
Good.
Inshallah.
No problem. Okay, anyone else want to go for any station? I know Dr. Suman Kumar cannot today. All the other members, Dr. How are you, Dr. Fatumata? Oh wait, when I'll end my sending, then I'll ask you. All right, if no one have